Hi, very good morning. I am Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. Today, in continuity with the previous lecture series on elementary system symptomatology, today I will be discussing on a H. pylori, or we call Helicobacter pylori, or the old term was Campylobacter pylori. This is a very useful topic to you in your everyday practice because we come across good number of condition of upper GI tract like GERD, gastric ulcer, duodenal ulcer, gastric carcinoma, gastritis, then GI tract lymphomas, gastric lymphomas. All those are due to Helicobacter pylori, or in short we will always use the word H. pylori. Hence we should be aware of it and it should be treated properly. We almost use the word eradication of H. pylori. So in that continuity we are going to discuss regarding H. pylori infection. So H. pylori, or another term Campylobacter pylori, that term is gone. Now we commonly use the word H. pylori or Helicobacter pylori. So Campylobacter or Helicobacter, Helicobacter means spiral or curved, or helical means curved or spiral. To a surprise, approximately 50% of the human population is already infected with H. pylori. This is basically a gram-negative bacterial infection with H. pylori as a cofactor in the development of the three important upper GI tract disorders. Particularly we use the word duodenal ulcer, gastric ulcer. Together we call it a peptic ulcer disease, gastric carcinoma, and then comes what we call as a gastric lymphoma, or it was previously called as gastric mucosa associated lymphoid tissue, or was labeled as a MALT. M for mucosa, A for associated, L for lymphoid, and T for tissue. So it was called MALT lymphoma, but now in short we call it a gastric lymphoma. So these are some of the conditions which are very commonly associated with H. pylori infection. H. pylori is the most common cause for peptic ulcer disease, which consists of both duodenal ulcer as well as gastric ulcer. Almost in 95% of patients with duodenal ulcer, H. pylori is positive. Well, in gastric ulcer, 80% of the patients with gastric ulcer are H. pylori positive. And almost 3% of the people, they have got lifetime risk of peptic ulcer because of H. pylori. It also gives rise to a condition we call as a chronic gastritis. It can end up with gastric carcinoma, which is accounting for the fourth most common cause in world for death due to carcinoma. So gastric carcinoma is one of the fourth common cause of death in world, and H. pylori is responsible for gastric carcinoma, and it is categorized as group 1 carcinogen. Increased risk of H. pylori infection for more than 10 years will be responsible for gastric carcinoma more common as compared to the other group of people. And also there is an increased risk of what is called as a MALT lymphoma, or we call gastric lymphoma, or mucosa associated lymphoid tissue. Lymphoid tissue. Now you can see here this is an H. pylori infection which is positive, which can end up with duodenal ulcer, gastric carcinoma, and gastric lymphoma. The incidence of lymphoma is very less, while duodenal ulcer, very high risk. Second common risk is gastric ulcer, Third risk, gastric carcinoma. So H. pylori positive are more prone for these four groups of disease: duodenal ulcer, gastric carcinoma, and gastric lymphoma, or we call malt lymphoma. So two diseases are very common due to H. pylori infection. We already mentioned 50% of the world population is infected with H. pylori, of which 15% of those infected people will develop peptic ulcer, which can be duodenal ulcer or gastric ulcer, of which duodenal ulcer is most common as compared to gastric ulcer. 5 million cases of ulcer in USA each year is secondary due to H. pylori infection. About 1% of well-developed gastric carcinoma is the leading cause. Here in this series it was third leading cause of cancer death worldwide, and we already mentioned Helicobacter means helical or spiral or curved. So as this organism is spiral or curved, it is labeled as Helicobacter, and it affects pylorus part of stomach, hence it was called as Helicobacter pylori. And you can see here it is responsible for duodenal ulcer, and later on it can get transformed into what we call as gastric carcinoma. This is a worst variety of gastric carcinoma. So H. pylori infection is bound to be because of Helicobacter pylori, and we already mentioned before 50% of human population is already having H. pylori infection. Now this particular bacteria is a gram-negative flagellated bacilli. It produces urease enzyme which breaks up the urea into ammonia and water. It can penetrate the mucosa, and it is responsible for duodenal ulcer. In H. pylori infected, 80% of people will have a H. pylori positive, when in gastric ulcer it is said to be 65 to 70%. So they are gram-negative, spiral road, unipolar flagellated. So there are flagella on one side mainly. It is microaerophilic, urease positive. Most common function of a bacilli is urease positive, which will split up urea into ammonia, which will neutralize with acid and reduces the acidic pH, and which helps to break down the mucosal barrier of gastric mucosa, and it can easily penetrate through gastric mucosa. So gram-negative, being a spiral, it is called spirochetes, do not invade the cell, but it only invades the mucous membrane. It breaks down the urea into ammonia, and because of this it will reduce the acidic pH, it will break down the mucosal defense mechanism, and it will produce chronic superficial inflammation. The transmission of H. pylori is from families to family, mother to child, sibling to sibling, and mainly the transmission in the family is gastric oral, oral to oral. Fecal to oral is not well recognized, but even some of the people do agree because of poor oral hygiene, because this particular helicobacteria are not detected commonly in feces, hence fecal-oral route is not commonly being considered. There is no environmental reservoir for this, but still contaminated water, it can be transmitted from animal to human being, and then human to human, gastric oral or gastro-oral, fecal-oral, oral to oral, etc. the common modes of transmission. So oral to oral fecal, infected human stomachs produces inflammatory response, and then as it is transmitted oral to oral or gastro-oral, so hygiene becomes very important to reduce the transmission of H. pylori infection. But all the people who gets an H. pylori infection does not develop peptic ulcer disease or gastric carcinoma. But in a person who develops a peptic ulcer, particularly duodenal ulcer, almost in 80% of the time it will be H. pylori positive. While in gastric ulcer, 65 to 70% of the time it will be H. pylori positive. And there is a 1% chance of person who is having an H. pylori infection to develop gastric carcinoma. So H. pylori will colonize in gastric mucosa. It will spread by oral to oral contact. Feco-oral spread is not very prominent. Poverty and overcrowding is the most common predisposing factor. Poor hygiene is another factor. And also transmitted within the families, mother to child, sibling to sibling, gastric oral, oral to oral, but feco-oral route is question mark, and we have already mentioned there is no environmental reservoir. Once it penetrates the mucosa, it will produce mild to acute inflammation, and that will give rise to what we call as gastritis. Gastric antral part is most commonly being involved, and it can also result into gastric metaplasia, which will be one of the factors responsible for gastric carcinoma and gastric lymphoma. As such, any part of the stomach can be involved because of H. pylori infection, and it will colonize over lying mucosa but does not invade mucosa. It will be on the surface of the mucosa. I'll skip this particular slide because the writing is not so very clear, but these are all the different factors: host factor, microbial factor, system factors. You've got host factor, genetic and non-genetic. In non-genetic, smoking, age, diet, and gastric pathology is responsible. Intragastric pH, which will depend upon the host genetic factor, proton pump inhibitor use, frequency, potency, administration, how long you are taking, relation to food, concomitant use of H2 receptor agonist, intolerance, pills burden, complexity, etc. will be also responsible when you are giving a treatment for any peptic ulcer or so. As far as a microbial factor is concerned, antibiotic resistance, virulence of the H. pylori, H. pylori bacterial loads, etc. Intragastric pH, all these factors will be responsible for effect of H. pylori on the stomach. And just skipping this slide. This is a simple slide which tells you that this is a microorganism, H. pylori, and this will synthesize urea, which will split up urease enzyme, which will split up urea into ammonia, and that will damage the gastric mucosa. Now at the same time, we do take some of the treatment like omeprazole, calithromycin and amoxicillin for killing H. pylori, but this repeated use, irrational use will produce resistance. But once this penetrates the surface of the mucosa, now there will be proliferation of H. pylori organism, and it will be responsible for gastritis and then peptic ulcer, and because of chronic infection, gastric carcinoma. So this is a slide which tells you the entire structure of H. pylori. There is an urease enzyme which will neutralize the gastric acid by converting the urea into ammonia at the level of gastric mucosa. Then there is a liposaccharide which adheres to the host cells and produces inflammation. There are other proteins which will help to adhere to the host cells. There are other factors also, flagella which increases the bacterial mobility and chemotaxis to colonize under the mucosa. There are exotoxins, which also produces gastric mucosal injury. There are some enzymes like mucinase, protease and lipase, which will also helps in producing mucosal injury, gastric mucosal injury. There is a secretion system for injection of effectors, and this particular will contain CAG-A, interleukin 8 induction, host cell growth and apoptosis inhibition, etc. will be there. So these are some of the factors which are there. This is in short high level of acid production. In place of even acid production, H. pylori can survive. This is a normal gastric mucosa. Now H. pylori, once it enters into the stomach, because of multiple mechanisms like urease enzymes, KAG, other liposaccharides, the secreting enzymes, etc., it will produce acute H. pylori infection. Now this will slowly over a period of time will produce chronic H. pylori infection, and when it is in the antral part, it will produce antral gastritis, which will end into duodenal ulcer, or it may produce asymptomatic H. pylori infection. Now second area which can involve the entire part of the stomach, and it is called non-atrophic pangastritis, which can end up into mild lymphomas, or it can end up into asymptomatic H. pylori infection. And this corpus predominant atrophic gastritis will end into gastric ulcer or asymptomatic H. pylori infection. And this gastric atrophic gastritis can produce metaplasia and can enter into a stage called dysplasia, and finally gastric carcinoma. So as the age advances, the chances of gastric carcinoma is much higher, and by and large the acute pylori infection will be converted into chronic H. pylori infection, and then there is a chance of duodenal ulcer, gastric ulcer, mild lymphomas and gastric carcinoma. Simply it is shown here very nicely that 50% of the people, because of host genetic factor, purulence factor, bone marrow derived cells, host immune response, etc., 50% of the people will develop H. pylori infection, which will be acute infection, and all this acute infection will be converted into, all 100% of this acute infection will be converted into chronic infection, of which 80% of the people will go into non-atrophic gastritis, non-atrophic pangastritis, 15% will go into antral predominant gastritis, and 5% will develop corpus predominant atrophic gastritis, or it is called multifocal atrophic gastritis. The antral gastritis, 20% of those people will go into duodenal ulcer, and 90% of antral gastritis, non-atrophic pangastritis or corpus predominant atrophic gastritis will develop asymptomatic H. pylori infection, and that will almost remains in 3% of the people lifetime, and less than 1% will be converted into mild lymphomas. Now from this corpus atrophic gastritis, 10% will be converted into gastric ulcer, 40% of the people will be developing intestinal metaplasia, of which 8% will develop dysplasia, and of this dysplasia 2% will develop gastric carcinoma. Sometimes this is even less than 1%. This is a simple slide, tells you what will happen once you get an H. pylori infection, and the end result is duodenal ulcer, gastric ulcer, mild lymphoma, gastric carcinoma, and 90% of the people will develop asymptomatic H. pylori infection. And this is a complicated slide showing you the different response at the level of mucosa, tissue damage, T cells activation, recruitment, etc. Inflammatory mediator release. There are many other slides. This is also showing you that urease enzyme will convert urea into CO2 detectable amount, ammonia, and then that will reduce the pH. There will be bacterial protein which can be detected in the stool in the form of antigen test positive. There will be KEG induced carcinogenesis. There is VAC-A mediated apoptosis. There are other factors which will give rise to infection, bacterial adhesions, damage to the mucosal layer, immune response, etc. And this is again that complicated side showing you the response of T cells, development of immune response, gastric lymph nodes, T cells manufactures, etc. The antigen of this H. pylori will be presented to the T cells, and then you will have an immune response. Complicated. I am not going into detail. Even I get confused. Simple way, H. pylori gets an entry with urease enzyme production, converts urea into ammonia and carbon dioxide, which will neutralize the gastric acid. Now, because of reduction in that gastric acid, now it gets a chance to proliferate. Then it will give rise to mucosal damage because of all inflammation and mucosal cell death because of different factors which are present in H. pylori bacteria. So pH reduction, it will activate the G cells. There will be increased gastrin, parietal cells, cell proliferation, increased acid secretion, chance of duodenal ulcer. So it will depend upon the H. pylori virulence, host factor, and environmental factor. Indirectly, because of all those factors, there are other factors which are there, which is called as a VAC-A, KEG-A. VAC-A is vacuolating cytotoxin, KEG-A is cytotoxin associated gene, then adhesins, and inflammatory protein A, etc. These are all the factors which will help this bacteria to produce a damage to mucosa, and that will aggravate the pathophysiology. So initially there will be acute gastritis. Chronic damage to gastric mucosa will produce chronic active gastritis, which will produce chance of gastric ulcer, which is almost 80 to 90% chance. Lymphoma chance is less, and gastric cancer is also less. There will be environmental factor will be also playing a role. This chronic active gastritis will be converted into multifocal atrophic gastritis, and that will be finally converted into gastric ulcer, gastric carcinoma, or gastric lymphoma. And the portion, if it is an antral predominant gastritis, it will be converted into duodenal ulcer almost in 95 to 100% of the people. And there is also a chance of lymphoma in the portion, that is antral portion, or maybe even in duodenum. So this will be the progress what will happen in a person who has got H. pylori infection. Same thing is shown here. Chronic infection, 85% of the time chronic gastritis, no clinical symptom, that is asymptomatic. In only 0.1% there will be mild lymphoma. 10% of the people will produce antral gastritis, increased acid production, no atrophy, so they will be more prone to duodenal ulcer. While corpus gastritis, decreased acidity, atrophy, and that chronic atrophic gastritis has got a high chance of gastric ulcer, and there will be intestinal metaplasia, dysplasia, and adenocarcinoma that can be there, and sometimes you can have even diffuse variety of gastric carcinoma. So these are, and this will be the histopathology. I am not expert in histopathology, sorry. So clinical presentation wise, approximately 50% of the people are infected by H. pylori. Good number of people are asymptomatic, and after acute gastritis, chronic gastritis can end up with duodenal ulcer, gastric ulcer, or mild lymphoma or gastric carcinoma. These are the four things which can happen in a person who gets a chronic gastritis secondary due to H. pylori infection. And because of H. pylori infection, person can complain of pain in stomach, which can be because of acute gastritis, chronic gastritis, gastric ulcer, duodenal ulcer. And also you can have pain in the epigastric region, also due to gastric carcinoma, and even in patient with lymphomas. Secondary to H. pylori infection, the good number of people also complain of bad taste in the mouth, little nausea, sensation of full stomach or bloating sensation, heartburns. Some people do also have bleeding from gums, belching sensation, decreased appetite, etc. are the multiple symptoms, and all these symptoms are almost very common in other group of people also, with GERD, functional dyspepsia, gastritis, gastric disorders, dysmotility syndromes. Also in case of gastric ulcer, duodenal ulcer, all those will have this group of symptoms. So abdominal pain, belching sensation, gastric reflux, mild nausea, etc. becomes a common symptoms along with H. pylori infection. H. pylori infection is also seen in a person with irritable bowel syndrome, or in short we call it IBS. Bloating sensation, distension, bad breath, anemia, and sometimes a chronic infection can also produce hypochlorhydria. So gas, bloating sensation, abdominal pain, acid reflux, anemia, and IBS of diarrhea variety are more common as compared to constipation. Now, once you come across any person with upper GI tract disorder which is for a long period, always look for H. pylori infection. And we always say non-invasive testing for H. pylori infection. Strongly recommended in any person who has got a chronic dyspepsia, who has got history of or who is having active peptic ulcer disease, you are suspecting mild lymphomas, or you are suspecting gastric carcinoma, following a gastric cancer resection, even following a peptic ulcer surgery, first degree relative of gastric carcinoma, or person who is on a long-term treatment with NaCID also, you should look for H. pylori infection, and by what we call as a non-invasive testing can be easily done. So for diagnosis of H. pylori infection, we have got an endoscopic diagnosis, we have got a non-invasive test, etc. So non-invasive diagnostic tests which are commonly being done in everyday practice are serological tests looking for presence of antibody. Urea breath test is another very common test which is a part of a non-invasive diagnostic testing, and stool in antigen. These are the three common tests which are routinely being done. And here you can see that UBT, H. pylori, SHAT, serological test, PCR, etc. While endoscopic test is biopsy, and you look for Urease test, histological structure, histopathology. You can go for bacterial culture, and you can go for PCR test. And there are a lot number of other, I am not aware of all this. So please forgive me for that. I am not expert in this particular field. So I am not aware of all this different technology for this short term. Yes, the most common tests which are being done in everyday practice is urea breath test, stool antigen, and in a blood antibody, presence of antibody, and endoscopy with biopsy. And we already mentioned person with dyspepsia, peptic ulcer disease, MALT syndrome, then unexplained iron deficiency anemia, thrombocytopenia, family history of gastric ulcer, person who is on long-term use of NSAID or aspirin, etc. You should do H. pylori test. So endoscopic biopsy, non-invasive technology. In endoscopic biopsy, after taking biopsy, look for culture, histopathological examination, and rapid urease test. These are most commonly being done. While in a non-invasive, antibody titer in blood, urea breath test, which is very commonly being done, and we also do what we call the stool antigen test. So in a blood for antibody, urea breath test, and stool antigen test. So endoscopic, histopathology, culture, and rapid urease test. In serology, antibody test in blood, stool for stool antigen test, and urea breath test commonly being done. So these are all the different tests which are being. This will be on histopathology. You look for that presence of H. pylori. You can go for rapid urea test after doing a biopsy, and you can also do what is called as a CLO test. You can, on an endoscopy, you can look for a gastric ulcer, duodenal ulcer, gastritis, etc. So that is including in a endoscopic diagnosis, and in a laboratory diagnosis we already mentioned. You can go for invasive and non-invasive technology. Any among non-invasive technology, in a blood antibody test, in a stool antigen test. So that will be the way you can go for. This is called CLO test, which is non-endoscopic urea breath test. You can go for that, or also after doing a biopsy, from the biopsy material you can go for the rapid urea test, etc. So urea breath test, how exactly is being done is mentioned here in detail. If you are interested, at your leisure time you can go through. Stool antigen test, now rapid kits are available. So immunoassay in a fecal sample can be done very easily. Biopsy urea test is very important and very specific, highly sensitive and highly specific. Culture and PCR is also another very important, but it is included in a invasive technology. Before you do a biopsy urease test, you must stop a proton pump inhibitor and other medication which may interfere 4 weeks prior to endoscopy. This is good number of time will interfere with your test, and false negative can be there if a person has got recent bled, or who is on proton pump inhibitor or H2 receptor antagonist, or who is on bismuth, etc., or who is on antibiotic for long term. So we should keep that thing in mind. There are good number of differential diagnoses which mimics upper GI disturbances like peptic ulcer disease, non-ulcer dyspepsia, GERD, functional dyspepsia, and other conditions like gastroparesis, pancreatitis, biliary hepatic disorders, malabsorption disorders, etc. Person who are on NSAID, all those should be screened for H. pylori infection. Now, as far as the treatment is concerned, empirical acid suppression, non-invasive test for HP, and then you can go for endoscopic test, and after that confirmation you can go for empirical eradication, or after confirming full eradication. So either by endoscopy or by non-invasive HP test, you have to detect scope positive, then directly you can go for eradication. If it is non-invasive, then treat positive cases. You can even start without doing testing in a HP suspected patient and go for a full eradication, etc. So in all this condition, you require HP eradication. peptic ulcer, definite case of H. pylori infection either by non-invasive technology or by invasive technology, malt tumors or malt lymphomas, H. pylori positive dyspepsia, asymptomatic groups also with H positive groups, GERD, family history of gastric ulcer, non-ulcer dyspepsia, and long-term risk of NSAID users. All these conditions you should go for H. pylori eradication. So definite indication, recommended indication, and possible indication. Definite peptic ulcer including scar, then mild lymphomas, early gastric cancer. Recommended gastric cancer, first relative patients, iron deficiency anemia, and chronic idiopathic thrombocytopenic purpura. Also in case of an atrophic gastritis, non-ulcer dyspepsia, long-term use of NSAID, etc., you should go for HP eradication. So current therapy, there are some challenges, there are some future therapies, etc. We have got triple therapy, so we use 2 antibiotic with 1 proton pump inhibitor, and person who are resistant to one of the antibiotic, it is replaced by levofloxacin or by bismuth compound containing bismuth plus 2 antibiotic and 1 proton pump inhibitor. That's why it is called bismuth quadruple therapy. There are a lot of challenges because of resistance to the antibiotics, and there is newer things which is coming up for in a future therapy, like supplementation of antibiotic therapy with probiotics, targeting biofilms, medicinal plants, vaccine, and use of antimicrobial peptides. These are the newer therapy which is in pipelines. In near future we will have something of this as a treatment part. So do not forget to have full eradication. There are some common side effects because of treatment like diarrhea, which is very, very common, and particularly Clostridium difficultis, almost in 30 to 50% of the people. Metronidazole produces a typical metallic taste which will reduce the appetite, and person can have little nausea, vomiting also. Some person rarely develops peripheral neuropathy secondary to metronidazole. Flushing and vomiting are quite common, particularly more common when the person takes alcohol and when he is on treatment, which is like antabuse effect. As such, because of 2 antibiotics, metronidazole itself can produce nausea, vomiting, abdominal cramps, headache, rash can be there, and antibiotic resistance. So bismuth can produce nausea, vomiting, unpleasant taste, darkening of the tongue, darkening of the stool, etc., and also little chance of renal toxicity. Yes, use of antibiotic, resistant to antibacterial drugs, and person will have a poor compliance because you have to give it for a longer period. Metronidazole will produce nausea, vomiting, unpleasant taste, decrease effectiveness of oral contraceptive pills. Also, it will have interference with lithium and warfarin. Amoxicillin and tetracycline has got good number of GI side effects in the form of nausea, vomiting, unpleasant abdominal discomforts, etc. It will also have interference with OCP. Pseudomembranous colitis is very, very common with amoxicillin as well as with tetracycline. And also lansoprazole will decrease the effectiveness of oral contraceptive pills. These are some of the common side effects, and because of those side effects, there is always a chance of treatment failure, and there will be poor compliance. In past, it was 2 antibiotic with 1 proton pump inhibitor, and it was given for 10 days. And because of all those problems, now new recommendation is triple 3 antibiotics plus proton pump inhibitor, and has to be given for 14 days. But you have to follow properly and observe for complications and side effects. So there is a triple therapy given for 14 days where antibiotic, usually two antibiotics are used, amoxicillin and clarithromycin with proton pump inhibitor, and this proton pump inhibitor S-omeprazole 40 mg BID or omeprazole 20 mg BID, amoxicillin is 1 gram BID, clarithromycin is 500 mg BID. In quadruple therapy, proton pump same dose. Now amoxicillin is replaced by tetracycline, which is 500 mg 4 times a day. Bismuth is 120 mg 4 times a day, and metronidazole is 250 mg 4 times a day. So you can see that this is 4 times a daily, and 500 mg has to be given for 10 to 14 days, by and large for 14 days. So side effects are more with these groups of therapy, but for eradication you will have to give for 14 days. So triple therapy is same like this, and bismuth quadruple is this. Now there is one more variety of therapy which is sequential therapy, which is day 1 to 5. We give proton pump twice a day, similar like triple or quadruple. Amoxicillin 1 gram BID, that is from 1 to 5 days, and 6 to 10 days. PPI dose remains same. Clarithromycin 500 mg BID and tinidazole 500 mg BID. This is called sequential therapy. So depending upon the person response, depending upon the tolerance, depending upon the side effects, etc. But most commonly preferred is triple therapy. And if there is a very high risk group for gastric carcinoma or person who is already having peptic ulcer in the form of duodenal ulcer or gastric ulcer, you will have to give quadruple therapy for full 14 days. Same thing is mentioned here. This is eradication therapy, triple therapy, quadruple therapy we already mentioned. At your leisure time you can go through. There was one name given to omeprazole, clarithromycin and amoxicillin, which is a triple therapy, was called OCLAM. O for omeprazole, Cl for clarithromycin and Am for amoxicillin. Some person use this OCLAM therapy as a word, but simple word is triple therapy. And when you use omeprazole, bismuth, metronidazole and tetracycline, this becomes quadruple therapy. Then it is called OBMT therapy. So this is quadruple therapy. So these are other terminology which some person are utilizing. So clarithromycin triple, bismuth quadruple and non-bismuth quadruple, where bismuth is replaced by another, that is proton pump inhibitor twice a day, amoxicillin, clarithromycin and metronidazole. So instead of bismuth, here amoxicillin is being utilized. Metronidazole remains same, and instead of tetracycline, clarithromycin is used. So these are the different permutation combination. You can see the eradication in triple therapy 70 to 85% of the time, in bismuth 75 to 90, and even in non-bismuth quadruple 90% of the eradication percentage. So if person is sensitive or allergic to penicillin, then you will have to go for macrolide. Does patient have a previous macrolide exposure? If answer is yes, you should use only bismuth quadruple. So you avoid macrolide as well as you avoid amoxicillin group. So clarithromycin, and if answer is no, then clarithromycin triple with metronidazole or bismuth quadruple is being utilized. Here if person is not allergic, then you can go for bismuth quadruple, levofloxacin triple or levofloxacin sequential. These are all the different permutation combination, newer and newer permutation combination is being utilized. So sequential, hybrid, levofloxacillin triple, levofloxacillin sequential, or bismuth quadruple, concomitant therapy, clarithromycin triple with amoxicillin, depending upon your resistance, depending upon all those. So there are different charts. Here see, if clarithromycin resistance is less than 20%, you can go for this. And if it is more than 20%, directly bismuth quadruple therapy or non-bismuth quadruple therapy. And if it is resistance is less than 20%, try with clarithromycin triple or bismuth quadruple in second line. So they divide into first line, second line and third line. In first line this therapy, second line this therapy, and third line this susceptible people, etc. You do a testing and then decide which treatment to be utilized. So they go for first line, second line, third line therapy. In a first line, hybrid therapy, sequential therapy. Second line you can go, and then if second line does not respond, then third line therapy. And now even in a third line, rifabutin based triple therapy is also being tried. At your leisure time you can go through. So first line empirical therapy, tailored therapy. Second line bismuth quadruple therapy, and in a third line levofloxacillin triple therapy or levofloxacillin quadruple therapy, etc. All permutation combination, but has to be properly selected and given for a full therapeutic time for 14 days. Again you can see here clarithromycin resistance, metronidazole resistance, and if a person is having what we call as dual clarithromycin and metronidazole resistance, etc. This is selection in a first line therapy, this is selection in a second line therapy, and this is in a third line therapy. So depending upon the resistance, depending upon the response, depending upon the side effects, etc., you select the therapy accordingly. So these are the current therapy, these are the futures which are now being tried in good number of people. Susceptibility based therapy, supplementation antibiotic therapy with now newer proton pump inhibitor, probiotic, targeting biofilms, medical plants, novel drug targets, etc. So these are newer things which have come up, and at present standard triple, levofloxacillin triple, bismuth quadruple, concomitant therapy, sequential therapy, etc. So at your leisure time you can go through and you can decide according to that, or you can always contact your expert. I am not that expert. Complications in any person who develops an H. pylori infection, 4 standard complications: duodenal ulcer, very high chance; second common, gastric ulcer; third common, gastric carcinoma; and least common, gastric lymphoma, or we call malt lymphoma. And person can remain gastric H. pylori positive for lifetime, almost in 3% of the people, and person can be asymptomatic. So there is one point: are some H. pylori good for you? Because we are having almost 50% of the people are having H. pylori infection. So it has been seen that there is an inverse association of gastric esophageal carcinoma and H. pylori prevalence. So do think of this. There is an inverse association with childhood asthma. So if H. pylori eradication is tried, there will be increased chance of childhood asthma or esophageal carcinoma or tuberculosis, etc. This has to be considered, and lot number of research is required in this particular group. So I end my lecture here. Thank you very much for taking out time. I know that your time is valuable, and I appreciate that you have spent some of the time with me. If you like the lecture, don't forget to press button like, subscribe, and you can share with your friends. And as H. pylori infection is almost common in 50% of the people, No doubt there are good number of people who are asymptomatic, but there is a very high chance of getting duodenal ulcer, gastric carcinoma, malt lymphomas, gastric malt lymphomas we call. You should pay attention to this particular group of people and see that if person starts developing symptoms, or even in a suspected person who is having a symptoms which are broadly suggestive of functional dyspepsia or GARD, or you are suspecting clinically duodenal ulcer, peptic ulcer, or clinically you are suspecting gastric carcinoma, or the person who are having a first relative suffering from gastric carcinoma, person who is on a long-standing use of NSAID, aspirin, etc. In all those groups, do investigate for H. pylori, and if they are H. pylori positive, either by non-invasive technology or by endoscopic, which is invasive technology, you should go for H. pylori eradication. And then depending upon resistance, compliance, response, etc., either you go for standard triple therapy or bismuth quadruple therapy, or you can go for levofloxacillin triple therapy, levofloxacillin quadruple therapy, depending upon the resistance to clarithromycin, amoxicillin, metronidazole, etc. You can, depending on that, and after doing a antibiotic sensitivity, resistance culture, etc., you can decide which therapy will be best for that particular person and give it for a full therapeutic period, that is for 14 days, and then can be followed by sequential therapy, etc. So I hope this lecture will be helpful to you. You can give your suggestion, and do not forget to press button like and subscribe, and you can share with your friends. See you in next lecture.